Sleep. We all need it. We often look forward to it. At one point or another, we're all deprived of it. Sleep has been hot in the headlines, and the search for a restful night of it has even claimed the lives of those in desperate want of it. Most recently, Michael Jackson has become the focal point of how destructive this search can be. Tonight, from relaxation to sleeping pills all the way to major medical implementation, how do we achieve a good night's rest? I'm Ernie, and this is Houston 8. Joining us tonight to talk about sleep are Dr. Todd Zwick, Medical Director of the Houston Sleep Center, and Dr. John Zerwas with Greater Houston Anesthesiology. Gentlemen, welcome. I'm sure you've gotten, it's been a very popular time for both of your fields right now with all that's been going on in the headlines. Place I want to start with is the misunderstanding I think a lot of people have of the difference between what sleep is and what being put under is. I'll start with you, Doctor.
Good point, and to some extent those of us who practice anesthesiology are guilty of promoting the idea that when you receive an anesthetic you actually are going to sleep or being put to sleep. And in reality, as Dr. Zwick will, I'm sure, attest to, is that sleep as a physiologic process that we all need is distinctly different than the use of an anesthetic agent and putting somebody in a state of anesthesia, whereby we significantly suppress all the brain activity in order that certain, perhaps uncomfortable procedures can be done safely and without any awareness on the patient's part.
So people who think being put under is a way to catch up on rest, not the same.
Absolutely not the same. Certainly anesthetic agents create a very comfortable environment for people to have surgical procedures or other invasive, uncomfortable procedures, but it is not a method by which somebody can catch up on the physiologic needs that sleep provides the human body.
I want to get a little deeper into that, but first I wanted to talk about also REM. And that rapid eye movement is really the point where, when you're sleeping, you get the most benefit, correct?
Well, we have two types of sleep. We have non-REM sleep, which accounts for about 75% of our nightly sleep. And REM sleep, which stands for rapid eye movement, is roughly 25% of the night. REM sleep is responsible for restoration of brain and intellectual functioning. Non-REM sleep is critical for body or somatic restoration, things like bone, muscle, cartilage. That is where the body, in its rest state, restores daily wear and tear. So you need both.
The non-REM sleep, is that similar then to being put out?
It perhaps would be closer to that, but even though somebody goes to sleep, if you put the EEG, the brain monitor, on them, you will see various brain wave activities and so forth. Distinctly different than somebody getting an anesthetic, where there is intentional suppression of a lot of that electrical activity. And so again, inducing a comatose state, which is a better way to describe the use of anesthesia and what we do to create that, calm environment, safe environment, distinctly different than what the physiologic needs and the things that are accomplished with typical human sleep.
A tiny bit off topic, but it was big in the news a little while back, was that when you're under a care of a doctor like you and you've been put in this comatose state, there was question recently of whether or not you're actually not feeling pain or you just don't remember what happened. There was all of these cases about people are actually suffering through this and they're feeling it, and then they come to and they don't remember. What actually is happening?
What you're describing is a rare circumstance called awareness under anesthesia. It is something that can happen. It is a very unfortunate circumstance. But somebody can be in a state of, what we think is a hypnosis and without awareness of any kind of pain or suffering, but they aren't able to move or make you aware of it. And that's because what we typically do in anesthesia is combine a muscle relaxant, not one that you could buy for aches and pains, but one that actually dissociates the muscles from the brain and the spinal cord pharmacologically. So you can't move. Those drugs don't create any anesthesia or any pain relief at all. And so if that medicine is on board, the paralyzing agent, but you don't have enough of the medicine that creates the hypnosis or takes away the pain, somebody could actually be awake and not be able to transmit the typical type of things that you would know. Movement, hands, arms, blinking, movement of the head back and forth and things like that. And so
that's
that is
rare.
Very rare,
Okay.
and one that people should be quite comfortable that that's why you do have trained professionals monitoring the circumstances under which the surgery is being done so that that does not happen.
And not to belabor the point too much more, one more question in this whole area.
Yes, sir.
Why do you not feel pain when you are put under? What actually is going on? If I'm asleep and somebody cuts me open, I'm going to wake up. I'm going to feel this.
Very good point. And just as a side note on that, that's one of the reasons that we have gotten away from telling perhaps children that, you know, we're just going to go back there and we're going to put you to sleep and Dr. X is going to take your tonsils out. Typically you'd think of a very painful process, and a child would turn to you and say, well, Dr. Zerwas, when I'm asleep and somebody just rustles me around, I wake up. Am I going to wake up during this time? And so the reality is when we give anesthesia, we're not putting somebody to sleep. We're putting them into an unconscious state whereby we suppress the centers that would record or register brain pain activity to an extent that we can do this. We typically combine the agents that put you in a hypnotic state, i.e. sleepy, with agents that also suppress pain, such as narcotics and those types of drugs that we know are very, very powerful suppressants of the pain recognition.
Okay, and I go over all of this just so that our audience understands the difference of what we're talking about. So Dr. Zwick, when someone comes to you and says, I really need a good night's sleep, I need to get this rest, what are the real options that are out there? I'm assuming the stuff that we're seeing in the Michael Jackson case is not something a doctor recommends as a way to do it.
No, absolutely correct. The first thing I tell my patients is that sleep doesn't come in a bottle. Very important concept, that the body has a wonderful protective mechanism. If you lose sleep over a period of time, your body will catch up. You do not get sick. You do not, in some cases, people think they'll die if they don't sleep. Not the case. And you've got to decatastrophize or let the patient know that in many ways they're kind of exploding the idea of lack of sleep, and they're creating more tension and more anxiety, and that in turn is causing more sleeplessness. Mm-hmm. So you've got to let the patient know that they can put it into perspective, that you do not die, you do not get sick if you have a night or two of poor sleep. We have all had that. Now, when they start to get strung together, you certainly develop daytime consequences. You have difficulty concentrating, you have difficulty remembering things, your psycho and motor performance can become impaired, and that's when you need to do something. And there are cases, and of course in my practice there are many of them, where we do use medicines to help augment sleep onset or to promote sleep maintenance. And there are lots of drugs that do that and do it very effectively and safely. But you've got to choose the right medicine for the right patient. You have to be able to listen to the patient, find out if the issue is I'm having trouble falling asleep, or I'm having trouble staying asleep, or both, and kind of provide the appropriate medicine for each of those conditions. There are enough medicines out there that one size does not fit all. And the doctor has to hear, and the patient has to be able to tell them what the issues are.
In researching this, I was speaking with a medical expert that I know, and he was saying when he writes a prescription for a sleep medication, Ambien or something like that, he will not give it with refills. It's maybe a 30-day supply, and if at that 30th day that patient is back for a refill, there are bigger issues here. That they should be adjusted. Sleep pills are an aid to get you back into a correct cycle.
There is a whole field of sleep medicine called behavioral sleep medicine, which is devoted exclusively to the non-pharmacologic treatment of insomnia. And this involves things like teaching the patient relaxation techniques, teaching the individual that They have to be able to kind of visually remove themselves from stressful situations. They have to be able to look at the bed and the bedroom as a place of relaxation, pleasure, and rest. Many people, after they string together a whole series of bad nights, come to look at the bedroom as a torture chamber, the antithesis of what you want in a place of rest. And I tell my patients, half jokingly and half seriously, a bed in the bedroom is a place for one of two things only.
Mm-hmm.
And if you're
eating and watching TV.
I think not.
Yes. But people fall into those traps. You get these habits, you think it's just another room in the house.
Anecdotally, I had a patient not too long ago who was a bond trader, and this is before the economic meltdown. And he came in and he described his bedroom to me. He had 2 computers, a fax machine, and 3 telephones. And he wondered why he couldn't sleep. And I said, well, how often are you using these pieces of equipment? He said, oh, the phone rings every couple hours. Every time something comes on the computer, I have it programmed so that the screen starts up. And I said, and you're wondering why you can't sleep?
Okay, I'm a big rock star, and I've got a world tour in front of me, and I've got a bunch of people depending on me. There's a lot of money on this and all that. Of course, I'm not going to be able to easily just turn it off at night and go to sleep. So I come to either of you gentlemen. What are the alternatives? What are you going to say to me? I mean, I'll start with you.
Well, first of all, I will say that that certainly isn't my area of expertise. Let me say what is not appropriate in those circumstances of which I have some level of expertise, and that is the use of agents that we would typically use, such as propofol, agents that induce an anesthetic state or have the potential to induce a deep anesthetic state or very deep sedation, are not the right thing to use. They are intended for different circumstances than for one to try to fall asleep or to stay asleep with regard to the things Dr. Zwick has just told you about. So those agents that I would typically use to create a successful anesthetic are not the right things to be used. Will they put you into this sleep-like state? Absolutely they will. They're very powerful drugs in that regard. And given in a certain dose at a certain rate, they will put you into such a deep state you will stop breathing, and then the consequences of that are obvious. So, those are the drugs that you typically would not use.
Let me ask this then, and I don't mean to change where we're going, but you say that this will put you out, will put you down. And Dr. Zwick, you said that your body will adjust in time. If you've had a bunch of bad nights' sleep, your body's going to find a way to catch up. What happens if each night the way you're being put down, in a sense, is by using a drug like propofol, and so you're not getting sleep, but this has been continuing night after night after night? What does your body do to adjust in that situation?
There are permanent changes that will occur. And these are not good changes. Over a period of time, you've got to understand that there's a difference between being made unconscious and having restful, normal, physiologic sleep. They are completely different animals. Apples, oranges, night and day, if you pardon the pun. But over a period of time, things such as your ability to go from a wakefulness center to sleep will change because your internal clock now is being altered chemically. What you want on a situation like this is if somebody has been doing that, and we see this in patients who have been in drug-induced comas for medical reasons, their sleep does take time to resume back to normal. And many times what we have to do is taper the agent that we were using for this medically induced coma and do it very carefully under very controlled circumstances. If it is done that way, then we can resume over a period of time a far more natural sleep. But it is a long, complicated process. And that's why, Dr. Zerwitz was very correct. This is not something any doctor would want to do on an ad lib basis. It's dangerous.
And Dr. Zwick brought up a good point. Very typically when I speak to patients about the anesthetic that they're going to get in, what to expect going into the operating room, coming out and recovering, what I will typically say, and especially to parents of children that are going to be having an anesthetic, is their sleep may be somewhat disturbed tonight. Probably not the next night, but it may be a little, the clock may be a little bit offset as a result of this, you know, and so I just give them that caution that, you know, if they're having trouble sleeping and so forth this first night, to expect that. That is one of the things that can happen when you receive an anesthetic, true in adults, true in children. Children tend to bounce out of an anesthetic and they're ready to go, you know, but then it comes night and then they fall asleep, but they wake right back up and so forth, you know, so it changes. For adults, we tend to just get drawn out by the whole thing, and we sleep pretty well, you know, but we still, our clock is reset a little bit. We have some awakening during the nights and things of that nature.
Propofol, we mentioned that a few minutes ago, and that seems to be the drug everyone's talking about in regards to Michael Jackson. Of course, we don't know as if this taping, autopsy reports, or anything like that aren't really back yet, so we don't want to rejudge that case or try that case. But I do want to talk about that drug a little bit, and what it exactly does, and why somebody would use it, or how they actually should use it, I guess is a better way to put it.
Well, it's chemically it's a phenol, and that's just the way it looks, you know, of chemically and how it's constructed and so forth. It's an agent which has been recognized to have very profound hypnotic effects. It's not a new drug per se. We've been using it in the United States for quite some time, certainly since the late 80s, early 90s, as the preferential drug to induce anesthesia. In other words, take them into that anesthetic state, and to sometimes maintain that anesthetic state if we give it through a continuous infusion. It has largely supplanted the drug called thiopental, a barbiturate that a lot of people are familiar with and was used for decades as the preferential agent. The uniqueness of propofol is it gets in fast. It's very reliable. You can count on it putting somebody into a deep anesthetic state if you give them the right dose. You can also expect that unless it's given as an infusion, that they're going to pop out of it in about 2 to 8 minutes, depending on what your own physiology and other drugs that may be given are.
And I read somewhere that's what makes it so desirable in a bizarre case like we're talking about, because when you stop administering it, it stops working.
And we call that the emergence from the anesthetic, and it's a critically important time, like flying a plane, taking off and landing. Those are the two most critical times in an anesthetic where you're disturbing somebody's physiologic status. And so, yes, they do come out of it very quick, and the nice thing about propofol versus thiopental is it does actually physiologically get out of your body faster. It's broken down faster and excreted faster by your body. But it also tends to leave you with much more of a state of well-being afterwards. And so we see it being used a lot for sedation, for things like colonoscopy, where most of us would like something to kind of put us out of that procedure or awareness of that procedure. It goes in very quickly. It's administered during the procedure by continuous infusion, or else given little bits of it, little volumes of it during the procedure. And people wake up very, very quickly from it, and they feel good. I can attest to that personally, having had that procedure done under that type of anesthetic. And it's a very comfortable wake up. You don't feel groggy, sedated like pentothal typically left you feeling.
And if you're just given a small amount, can it just bring you down to a euphoric state as opposed to putting you under? Can you
absolutely,
limit it that way?
absolutely. It can create. It's very good in just a small amount in allaying anxiety, and we use it for circumstances where we're not going to have somebody off into a deep sleep, such as if we're working on somebody's foot for a bunion. We may put in certain blocks in and around the foot, but the person is still anxious, and not uncommonly we'll use that drug in smaller doses as a continuous infusion or as small little incremental doses just to allay the anxiety. Their respirations may slow down, but they don't stop. They may get sleepy looking, but they may not fall off into a deep sleep. And so it is used for purposes like that, but again, we use that where you have all the sophisticated monitoring, all the trained personnel to watch somebody who's receiving that type of medication.
Dr. Zwick, if in fact you have the correct monitoring and all of that around, could putting somebody to a more relaxed state lead them then into the sleep that you want? Is that a logical progression?
Well, The sleep that you want, you have to define what want is.
The healthy, rejuvenative.
No, this is not going to give you a healthy, rejuvenative
So a slight
sleep.
sedative does not help to lead to good rest.
That is correct.
But a lot of people, I would assume that that would happen.
Well, again, there's a difference between being unconscious and being asleep.
Right, but if you're just taking the edge of anxiety off somebody, does that then put them in a state where it's easier for them to go to sleep?
In a patient who is not acclimated, or if you want to use the word addicted to it, yes. It's somebody who is drug naive or has not used it before, yes, take the edge off. You can allow natural sleep to come on. The problem is that after you've been using it on a continuing basis, that paradigm is lost. The person becomes literally, physically, and psychologically addicted to the need for an agent to, quote, put them out. Mm-hmm. And over a period of time, particularly if you're doing it all night long, you are not going to get anywhere near the sleep that you, quote, need. You certainly are not going to have the slow wave sleep you need, the REM sleep that you need. It is a very artificial and a very bad state to be in night after night after night.
I'm going to pull out of all of this theoretical and stuff that most people will never encounter in their lives. Most people are not going to put a drip in their home to go to bed at night. But I do wonder, people do things at home. They think they'll have a drink or two before they go to bed, and that's going to relax them and they're going to go to sleep. And that's where I'm heading with that line of questioning is there are things we do that we think will lead to a better night's sleep. Help me understand what does work and what doesn't.
Okay. Alcohol is the oldest sleeping medication in the world. Been around for 5,000 years. Alcohol works on the brain. It is a relaxant in terms of both central nervous system or cortical activity, and it is a muscle relaxant. You feel better. It takes the edge off, as we just discussed. But alcohol is a very major double-edged sword because alcohol affects normal brain chemistry. Alcohol, when you first start taking it, can bring on an earlier REM sleep if you are not addicted to it, and perhaps even some increase in slow wave sleep when you first start it. The problem is that after you've been taking it for a while and after you have that first drink, when the alcohol is metabolized, there is a rebound of slow wave sleep and REM sleep. People develop nightmares. People then have a substance on board called acetaldehyde, which is the main metabolic product of alcohol. Acetaldehyde works as a stimulant. So after you take the alcohol ostensibly to help you sleep, 4 to 6 hours later, you now have a stimulant on board. And I tell my patients it's the equivalent of 2 grand lattes from Starbucks. And so early morning awakening, complete inability to fall asleep, restlessness ensues. So alcohol may help at the beginning of the night, but it's a terrible agent for the second half of the night.
Earlier on, we were talking about being put under anesthesiology and about when it puts you into that like coma state. I think we've all been there where we've seen somebody who has had so much alcohol that they pass out. In those conditions, are they asleep and it's a restful sleep when they have finally hit the point, or is that similar to what we're talking about?
It's not a restful sleep at all. It's a very agitated sleep. Breathing becomes irregular. In fact, one of the issues is that we see patients who drink excessive amounts of alcohol who may have underlying sleep apnea. This makes it much worse. Oxygen levels drop profoundly. People stop breathing for longer periods of time. You get what we call surges in critical hormones that we use, cortisol, epinephrine. These are stress hormones. So what you're doing is you're adding to the body's stress as opposed to taking away from it. So
right.
It is detrimental and not beneficial.
Well, doctors, in like 2/3 30 seconds we have left, what can you say to wrap this up for us?
Well, I think what you've heard both of us speak to in our own specialties, that there is a clear distinction between agents that are used to produce anesthesia and agents that are used to help induce physiologic sleep, and the difference between anesthesia and physiologic sleep. And although to the passerby it may look that somebody is very restful and comfortable, what is actually going on in their brain is distinctly different, and that activity that's going on in the brain is essential for the human being to exist and to function well. What's going on between the brain and an anesthetic state is essential for a procedure or surgery to be performed safely and effectively. One is not the other, clearly, although to the passerby looking at that, it may seem to be that way.
Doctors, you know what? We are out of time. Thank you very much. I know that there's a lot going around in both of your areas of expertise right now because of that, so thank you for taking the time to come in here and help us understand what's what and all of that. Now, each week we invite you to visit our home online at HoustonPBS.org. Simply click on the local programs bar, pick Houston8, and then you can join our online community. Read about the guests, learn more about the topic, share your thoughts and ideas, and even suggest questions that we might ask during upcoming episodes. Remember, information posted on our website may be used on air, so keep that in mind when submitting. That does it for us tonight. Until next week, thank you for joining us. I'm Ernie. Have a great week.